Alright, so I kind of just lumped a bunch of testicular pathology together in today's lecture. So I'm going to start with cryptorchidism. So this occurs when we have one or both testes that don't descend into the scrotum. And as you can see in this image, we have a right hemiscrotum, and right cryptorchidism, and you can see down here that there is a hemiscrotum because the right side is empty. So obviously you have an undescended testicle. So because there is an increase in body temperature inside the abdomen versus in the scrotum, these testicles are lacking spermatogenesis. So we are at an increased risk for germ cell tumors and an increased possibility of infertility. So do we remember which type of cells is not affected by temperature changes in regards to the scrotum? So we have Leydig cells and Sertoli cells. Which of them are not affected by temperature change?
Sertoli?
Actually, Leydig cells. So
okay.
It was a 50-50 shot. Okay,
yeah.
but Sertoli cells are affected by temperature change. So we're getting a decrease in inhibin B, which is what Sertoli cells of FSH. So because of that. And testosterone is only going to decrease if they're bilateral. And that probably has to do with the testosterone feedback from the increased LH and FSH. Okay, so now we have testicular torsion. So this is when we have an abnormal twisting of the testicle around the spermatocord. So because of this, we're going to have a lack of venous drainage from the organ, and it becomes hypoxic. And that's because we have, if we're looking at this healthy guy, we have both a testicular artery and a testicular vein. But remember that the testicular vein is thin and floppy. There's a large lumen in there. So the vein is what's going to get compressed. And so you're not going to have outflow. And so that's where you're going to get the, the necrosis associated with testicular torsion. It normally occurs in males ages 12 to 18. It's acute, severe pain. On physical exam, you're going to see a high riding testis with zero cremasteric reflex. You remember what the cremasteric reflex is?
Something about stroking the thigh.
Right. So you stroke the inner upper thigh, and the cremasteric muscle will contract, and you will see the testes ascend up towards the trunk.
So the reflex is normal?
No, there's a lack of this reflex in...
If you have a torsion.
Correct. We have
that so in normal
the
reflex is seen?
Yes.
Okay.
So you can do this on a well, no, it would have to be on at least a teenager probably, but if you did this on a male patient and you just stroked the inside of their thighs, the testicular sac would rise towards it, but in this one there is no cremasteric reflex.
Okay, got it.
Okay, so I don't have it on here, but do you guys remember what Pren's sign is? So this Pren's sign is when you have a patient lying supine on the table and they are in testicular pain, like we got a guy here with testicular torsion, they're in pain, and you, if you want to say it, you cup the scrotum and you will elevate it towards the trunk. And Pren's sign is that elevation of the testes relieves the pain, and that is positive in epididymitis, but not in testicular torsion. So in testicular torsion, your cremasteric reflex negative, and you are Pren sign negative. So,
no relief of pain during performing the test.
Correct.
But in epididymitis, it does relieve pain.
Correct. So I don't think that's in first aid. I don't even know if epididymitis is in first aid, but I saw it on my UWorld notes when I was looking at it today. So, anyways, so important thing to remember here is that testicular torsion is a surgical emergency. It needs to be corrected within 6 hours, or the only option is to perform orchiectomy. So orchiectomy is removal of the testes, but orchiopexy, which is a permanent fixation of the testes to the base of the scrotum, is performed sometimes bilaterally, because if you do have a patient that has a prematurely ascending scrotum back up in through the why can't I think of the outer? Oh, someone help me. Where's the
fascia?
Sorry, what are you asking? Trying to remember.
Yeah, where do the
You were explaining orchiopexy, right?
Yeah, what is it? Where is it that the I sound like a fucking idiot right now. I can't even think what the hell this is called. The spermatocord. Where does the spermatocord exit through? The external inguinal. Okay. Anyways, if you have a testy that ascends up back up into the inguinal ligament, then sometimes they perform a bilateral orchiopexy because both of them have increased chances. If one testicle ascends, there are increased chances that the other will do the same. That's what I was trying to say. Sorry.
Wait, so in the torsion, ascension, that's not a word, but occurs? The testes ascend?
So it can occur with testicular torsion, or it can occur spontaneously. But so what they do is they unravel this guy, and then they tack it down to the base of the scrotum. Mm-hmm. But if you had a patient where it spontaneously elevated, and then they brought it back down and tacked it down, a lot of times they'll tack down the other guy because there is an increased chance that there's bilateral ascension. So they'll just do a bilateral orchiectomy as a pre-measure.
So the orchioplexy procedure is basing it down versus orchiectomy is just cutting it out.
Yeah, orchiectomy is like your testicle is dead. We cannot save it.
Okay.
And also, I didn't mention this, but it says acute severe pain, and very frequently it's due to trauma. Like I had my godbrother actually had to have half of his testy removed because of this, because he was playing soccer and someone missed the soccer ball and hit his instead, and so they only could save half of it. And I've heard a lot of those teenagers that do those skateboarding videos that land on their balls. Yeah, they don't always survive those either. So yeah. All right, so next we got varicocele. So again, another benign condition. that is describes dilated veins in the pampiniform plexus. And most common cause of scrotal enlargement in males, and is due to increased venous pressure. Excuse me. And it is frequently described as a bag of worms, and it typically occurs on the left side. Now, why does it occur on the left side if we remember our venous anatomy of the testicles?
The left testicular vein drains into the left renal or left renal vein,
right,
versus the right side goes into the IVC.
Right. What other vein on the left side also drains into the renal vein before moving on to the IVC?
Testicular or no?
Well, yes.
In addition to
this is the testicular vein. There's another one. So we got the testicular vein. Here's the kidney vein or renal vein. And here's the IVC. But there's something else that also drains into the renal vein. The adrenal vein. Make sense? Yes? No?
Okay, yeah.
Let's see. So it can cause infertility, and that's because, again, just like we had in cryptorchidism, you have a lot more stagnant blood flow here. You're going to have an increase in temperature, and the testicle's not going to like that, so you can cause infertility. So you're going to have an increase in the bag of worms with Valsalva because you're decreasing venous return, and it's going to decrease by laying down. And it's going to be negative on transillumination because it's not going to transilluminate because it is blood and you're not going to have, it's not a clear fluid. Okay. Any questions on varicocele? Oh, and I have here a Doppler that is showing down here is showing increased Doppler flow, but also here it's showing the increased space within the testicular veins. All right. So extranodal germ cell tumors, they normally arise in the midline, and depending on the age, form different spots. So this is a sacrococcygeal teratoma, and in adults, it'll end up being a retroperitoneal or mediastinal tumor. But that is literally all I have for that. So we'll move on. This is, basically, if you just see a child born with a giant tumor, just extragonadal germ tumor. So, moving on to scrotal masses. First, we have congenital hydroceles. And so this is a benign tumor, and this one, the key feature on this guy is that it is positive on transillumination. So you put your pen light up to it, and you'll see light shining through. And so it's most commonly a swelling in infants due to a patent processus vaginalis. And it's normally benign, and reassurance is basically what you do with this case with the parents. Just say that it'll spontaneously regress. Then you have acquired hydrocele. So again, we've got a fluid-filled sac along spermatocord within the scrotum, and this can be secondary due to inflammation or infection, tumor, or trauma. So if it's blood instead of just serous fluid, then it's called a hematocele. So if it's a hematocele, it will transilluminate. But if it's just inflammatory tissue or serous tissue, then it will transilluminate. So we have spermatocele, which is a dilated epididymis, a duct of the epididymis, which is from, again, physical trauma to the epididymis. So the difference between the fluid from the spermatocele and the fluid from the hydrocele is that this guy has spermatozoa in it. So essentially, this is going to be like a rupturing of the epididymis, which is going to leak spermatozoal fluid into the scrotal region. And so I'm assuming this one won't transilluminate either, if I had to guess. All right, so testicular germ cell tumors. We've got germ and non-germ cell tumors. So most of testicular tumors are of the germ cell class. They account for about 95% of all testicular tumors. Risk factors include cryptorchidism and Klinefelter syndrome, and they are solid organ tumors, so they will not transilluminate. So seminoma is the most common testicular tumor, and it occurs most frequently in males between ages of 15 to 35. So although this name sounds benign, seminomas are malignant, and they tend to show up as painless masses. And you can also get some lower back pain if they metastasize to the lower peritoneum. So in histology, you'll see this fried egg appearance. Well, I won't necessarily circle individual cells, but you can kind of see a bunch of these guys here look like fried eggs. And this is similar to the dysgerminoma found in females. So even though these lesions are malignant, they're very responsive to radiation therapy. And if they do metastasize, they tend to do so late. So what is the tumor marker that is associated with seminomas?
AFP?
Close.
ALP?
ALP. Placental alkaline phosphate. So next we have a yolk sac tumor, which is similar to the ovarian sac tumors in females. And these get aggressive and can metastasize. So they are also associated with elevated AFPs, just like we have here. And on histology, they have these things called Schiller-Duval bodies. So what are they supposed to resemble again?
Glomerulus.
Yes, glomeruli, yes. There's a couple more glomeruli looking things. Okay. Choriocarcinomas are caused because of disordered syncytiotrophoblastic and cytotrophoblastic elements. So they're going to have elevated HCG levels, and they're going to spread hematogenously. Okay, so any tumor that has elevated HCG can have symptoms of hyperthyroidism because HCG is structurally similar to what?
TSH, LH, FSH.
TSH, LH, and FSH. Very good. Teratomas in males are often malignant compared to the benign dermatoid cysts or teratomas in females. So again, in this image, you can see a teratoma has multiple types of tissues, hair, teeth. I guess you can't really see hair and teeth so much in this one, but you can see that they're distinct different types of tissues when looking at it. Embryonal carcinomas are very painful as compared to seminomas, like we talked about earlier, which is a painless mass on the testes. These are painful and have a really bad prognosis. And about a third to a half of patients present with metastases at the time of diagnosis. So they tend to be undifferentiated, granular, and papillary in morphology. And they're often mixed with non-seminoma tumor types like yolk sac tumors. So these guys also will have elevated AFP and elevated HCG. I might do that wrong, but these markers are coming from the other tumor types and not from the embryonal carcinoma tissue itself. So, as a quick recap, amongst testicular germ cell tumors, seminomas are the most common. They account for about half of all testicular germ cell tumors. Second most common are the mixed germ cell tumors, such as the non-seminomatous ones that we talked about. And those alone make up for 1/3. So stupid sentence I just said. Okay. Okay, so all of these guys and seminomas, so all the ones that we just discussed, make up for about a third of all testicular tumors. Okay. So now we're going to go to the less common testicular tumors. These are the non-germ cell tumors. All right, so they're only 5% of the testicular tumors, and they are mostly benign with the exception of a testicular lymphoma. So first off, we've got Leydig cell tumors. So we know that Leydig secrete androgens, so they can cause precocious puberty in boys. And in some cases, they can also secrete estrogen and cause gynecomastia. So classically, these tumors have a golden brown color, and on histology, you can see these Reinke crystals within the cells. So the Leydigs have the Reinke crystal. I actually totally forgot about that till just now. Sertoli cell tumors can also secrete estrogens, which can lead to gynecomastia and impotence, and they are often called androblasts. Yeah. And so, like mentioned earlier, the testicular lymphoma is the most common testicular cancer in men over 60. And it is almost always a non-Hodgkin lymphoma, and the most common type is a large B-cell lymphoma. So it does form metastases, and it is a very aggressive and hemorrhagic tumor. So not good there. So what is the most common testicular germ cell tumor, and what is the tumor marker associated with it?
Seminoma, ALP.
Yes, placental alkaline phosphatase. Okay, so I didn't get a chance really to put any questions up, but I do have a few just like quick quiz questions from my notes here that I was looking at just before we started. Okay, so what would be, okay, if we have a Leydig cell tumor, so what do Leydig cell tumors secrete?
Androgens?
Androgens. So what would our LH and FSH levels be in a Leydig cell tumor?
High?
So if we have
Or both? Because we said the Leydig, like, it caused precocious puberty. So
in a male, though, LH and FSH stimulate androgen production. So if we have ectopic androgens being made, we're going to have low
decreased
LH and FSH levels because the hypothalamic pituitary axis is going to be shut down because we got ectopic androgens being made further down.
Okay,
so
yeah, that makes sense.
Low LH, low FSH, high testosterone, high estrogen, and then the gynecomastia. So this is kind of a mean one. In what clinical scenario? So this is a embryologic reproductive pathology. In what clinical scenario would you have to perform an orchiectomy on a female to prevent testicular tumors from happening? I know, it's a mean one.
So, like the tunica vaginalis, like.
Say it again.
Oh no, that's a hydrocele. I don't know.
When you have.
Basically you have to ask yourself, when would a woman end up with testicles? And on top of that, they have to be internal.
So like hermaphroditism.
You're on the right track with that. Same page.
Internal genitalia versus external genitalia.
Right. But
would that be like a Leydig tumor, Sertoli cell tumor?
No. Those are tumors. Oh, it could maybe turn into a Leydig cell tumor.
Embryologic. So orchitis in a female who's a male.
It would almost be like crypt orchidism.
Yeah, crypt orchidism. Oh, so that's the right answer. Or are we not at the answer?
No answer yet. So
you're saying the equivalent of crypt orchidism in a female? Right. A femoral hernia? No.
No, it's when you have a female, but she has testes that are stuck inside. But she has external female genitalia, and I can't remember the name of it.
Correct.
Not androgen insensitivity, not
actually
androgen insensitivity syndrome.
Testicular feminization? No, that's what happens in it. With the disorders of sex development, I forget the name. I can't remember.
No, still see it's androgen insensitivity syndrome, and the reason for it is that you have the male, it's a female, but they are XY. So the thing is that they have testes, but because they don't have peripheral tissue that will accept testosterone. So these testes are making testosterone, but their entire body is insensitive to androgens. So they're not going to develop secondary male sexual characteristics. So they don't make, they do make mullerian inhibitory factor. So they don't have uterus, fallopian tubes, ovaries, or the upper third of the vagina. But they don't create penis, scrotum, prostate, or anything like that because they don't make they're not receptive to testosterone, but they're making it, churning it out. So because of that, there's so much peripheral testosterone, it'll eventually turn into estrogen. So these patients will develop secondary female sexual characteristics like breast tissue development. But at the end of puberty, you have to remove the testicles because they can develop testicular cancer.
Why would you wait for the end of puberty?
Because if you do it, this patient is going to be a female that presents to you at age 15 saying, "Doc, I never got my period," or "Why does it hurt to have sex because my vagina is so short?" It's probably not going to be something that you discover until then. But also, if you do discover it, let's just say on ultrasound randomly, or you see crazy high testosterone levels, if you do that, you remove their source of estrogen because they're getting their high estrogen source from, because remember, they don't have ovaries, they've got testes. So you'll remove their estrogen source, and you're going to have it'll be like neutering a puppy. It'll be a puppy forever. Well, in brain development at least. So I thought I'd throw that out there because I saw it on one of the lecture videos I watched today, and I was like, that is a shit question, but I'm doing testicle stuff today, so I may as well throw that one out there. So,
yeah, that's good. Interesting. I guess it's also called testicular feminization.
Right. Which, yeah, that did is that the 2015?
17.
And it's labeled as testicular feminization?
Well, it has AIS, but before it also has DSD, with the alternate name being testicular feminization. So
DSD being
disorders of sex development, and as 46XY DSD, and then
just as the title for,
and then it lists androgen insensitivity syndrome, also known as testicular feminization, as the most common form of that.
Yeah. Because the other one, and in this video, the guy's doing a parallel saying mullerian inhibitory anti-mullerian syndrome, or what is it? Anti-mullerian.
Mullerian agenesis.
It's a mullerian agenesis. Thank you. So mullerian agenesis and AIS present the same way, except in mullerian agenesis they'll get body hair, whereas in AIS you won't. And in AIS, you have to perform a orchiectomy eventually because of the risk of cancer. Whereas in mullerian agenesis, they just never developed that.
And AIS has higher testosterone levels than mullerian agenesis.
Yeah, that makes sense, I'm guessing. Unless it says something else. So yeah, because they have testes. So yeah, that's all I got for you today. Can't think of anything else. So I guess, actually, yes I did. Never mind. Now I remember. Okay. Because I told Tulsi I would do this last week. So we have a patient that presents to you stating that they yesterday when they were changing, they noticed brown reddish stain on their left side of their bra. What breast pathology might you be thinking of? A reddish, brownish stain on their left bra, or the left cup of their, you know what I'm saying?
Paget.
It could
No.
be, but the question is going to be, what is the
There's
most...
a more benign. Yeah. Intra.
Yes. Yes.
Intra. Something dysplasia. Oh my god. Intra.
Intraductal papilloma.
Yeah.
Intraductal papilloma. Because Paget's could cause either serous or bloody fluid, but the most common cause of bloody discharge from the nipple is intraductal papilloma. And if you're going to get a Paget's question, it's probably going to say itchy, swollen, eczema-like around the areola, as opposed to discharge. Paget's normally has that, like, you know, nasty, crusty appearance to it. And the discharge is just secondary to that. Okay. What is the... you have a patient that found a few hard spots on her breast. She's an avid runner, and she wants you to do a mammogram on her right away. Let's say she's on the cross.
Dysplasia.
Fibrosis
Hard
changes.
masses.
Yeah, a few masses on her, and they get bigger during her menses.
Oh, not fibrodysplasia? We said no to that?
Is that an option? Isn't it called something else?
Fibrocystic
Oh.
changes.
Fibrocystic
Probably.
changes.
Oh, yeah.
So fibrocystic changes are very common, and then they can happen from trauma, they can happen from car accidents, stuff like that, and they are cyclic. Now, what is the difference between fibrocystic changes and a fibroadenoma? Both breast pathology. Because I got this question today, and I was like, motherfucker.
Fibroadenoma is not trauma associated?
True. Except, but...
The changes are, like, always persistent? I don't know. Like, not necessarily associated with
No, they're both
menstrual cycle?
They're both cyclic. Both cyclic. And Divya, the reason I was pissed off was because the girl was a runner with large breasts in the question. So they got me on that. The difference is fibrocystic changes are normally small, multiple small areas on the breast that a woman will say, hey, I feel here and here and here, whereas a fibroadenoma is one small, rubbery, mobile mass that is cyclic, changes in size during menses, but it's a single one. Fibroadenoma, I'm remembering it, fibroadenoma, there's one, and then there's fibrocystic changes, there's multiple changes. So that's how, I never heard that, but that's the question that I got today in UWorld, so I was like, let's see if I got any other breast questions today. If we have a patient that comes in complaining of the fact that she can't shop for bras anymore, so she stopped wearing them because one of her breasts has been slowly enlarging over the last 4 years. On an examination, she indeed has a very distinguishably large pendulous right breast compared to her other breast, and it is hard to palpation. again, compared to her other breast. Typically unilateral, massive breast. I remember Dr. Jane showed us a picture of this in Path, and I will never forget that photo. It was fucking disgusting. This is the phalloides tumor. So normally unilateral, and it's, I mean, again, I'm sure women would probably present before what Dr. Jane showed us, where one of them was like, you know, looked like a punching bag versus the other one.
Did it
So
give you an
tumor.
age?
I'm sorry?
Did that question give you an age?
That I didn't get a question on phalloides today. I was just remembering stuff from last week. Okay, here's a question I got today. Okay. Oh, okay. Here was another asshole question. You have a patient who. All right, never mind. We'll do the easy one first, and then we'll go to the harder. We'll progress from there. So you have a patient who gave birth to her first kid about 6 weeks ago, and she is both breastfeeding but pumping throughout the time when her child is sleeping so that her husband can take some shifts on feeding the pumped milk while she gets some sleep. And she wakes up and she's got a warm erythematous breast. What's the
Mastitis.
Lactational mastitis. What is the most common organism?
Staph aureus.
Staph aureus. And what is the recommended treatment?
Continue breastfeeding.
Right. So now, got another patient. Same clinical scenario, except she comes to you and says, she has a fever, erythematous, and it's warm to the touch. There's a mass on the upper outer quadrant, and there's some dimpling of the skin. It's a hard mass, dimpling of the skin. There's a little bit of discoloration there, too.
Inflammatory breast cancer?
Inflammatory breast cancer. You might say it looks like the peel of an orange. Yes, inflammatory breast cancer. And that was the question. It was a straight-up mastitis question. But then they said skin dimpling and that it was in the outer quadrant. Because normally mastitis hurts like right around the areola. And you're only thinking like an ascending infection if they didn't treat it, if it was long-term or like multiple times. But they threw in skin dimpling right at the end. And I was like, okay, this has to be inflammatory. So yeah, we're trying to. So you helped me today, Tulsi, for making me do that breast pathology last week.
Thanks. I guess it's a win-win.
All the other ones were all like, what is the next step kind of stuff, which is basically all just biopsy. Except for like fibroadenoma and fibrocystic changes. If you get anything cyclical, you basically don't touch it. What drug can we give to help prevent breast cancer?
Clomiphene? No, trastuzumab?
Yeah.
If you have the receptor.
Right, if you have the HER2 receptor. So what if we have an estrogen receptor positive breast cancer?
Tamoxifen,
Clomiphene? Tamoxifen?
Tamoxifen.
Okay.
Can you give clomiphene for that? I'm not sure.
Maybe not. It's more like a clomiphene
is for PCOS.
It's like it's like a leuprolide type of thing.
Yeah, you're leuprolide, you're stimulating GnRH long term, and that's what will shut down the hypothalamus, whereas clomiphene inhibits GnRH. So they both do the same thing, just different mechanism. But you're right, tamoxifen because it's a selective estrogen receptor modulator. So it is an antagonist on the estrogen receptors in breast tissue. So it'll stop that. But what is the risk factor with tamoxifen?
Endometrial.
Right, because it is also an agonist at the endometrium, so it can cause endometrial hyperplasia, which could lead to endometrial cancer. Right. I think that's all the breast stuff I got today. Trying to think of any other. I think we covered all the main, like the big breast pathologies, anyways, just now. So. Yeah.
Can we real quickly re-explain why the testicular torsion, is that what I'm thinking? Why it's more common on the left versus the right? Is it because it's more connected to the, varicocele? Like, I know, I'm just like trying to picture it more. I used to know it so well, and now I'm like, I forgot exactly why though.
Because there's more vessels interacting with each other on that side, you have more resistance to blood flow coming back up.
Okay, yeah, because of the veins and the whole connection with the plexus.
Right, so it's going to have a harder time going back. So it's just a resistance issue.
Okay, yeah. All right.
Share my screen again.
Increase resistance to flow from left gonadal vein drainage. Yeah, this is just resistance.
Can you guys see my screen?
Mm-hmm.
Yes.
Yeah, so you have this. Okay, we'll start with the right. This is the simpler one. The right testicle goes all the way into the IVC, and it doesn't run into any resistance. But here, there's a 90-degree angle where you will where it encounters the right renal vein. So if there is any kind of increase in pressure, there's a decrease in laminar flow. You'll get more turbulent flow. So it's gonna, like, kind of like when you see a stream run into the ocean, you're going to get a bunch of waves here. So you're going to get a decrease in flow. And it's going to back up all the way to here.
Okay.
And so these veins, that bag of worm, it's all this pampiniform plexus swelling up with excess.
All right, perfect. Thank you. That was very helpful. We'll put together your and Divya's explanation.
Teamwork.